I'm Ramaswamy Govindan, a professor of medicine at the Washington University School of Medicine in St. Louis. The question is, how do I treat patients with limited stage small cell lung cancer? And of course, this presumes that we have done comprehensive workup. Today, in my opinion, PET scan is an important part of that. In fact, many years ago, Dr. Jeff Bradley, my colleague, former colleague here at Washington University, and I did a study where we asked the question, does PET scan add anything to patients with limited stage small cell lung cancer, who are deemed to have limited stage small cell lung cancer with conventional workup then? And it turned out that the PET scan identified occult metastatic site in about 20%. In other words, metastatic sites not appreciated, particularly the adrenal glands that showed up on the PET scan. More importantly, it helped refine the radiation treatment plan, the PET scan. So in my opinion, PET scan is a standard part of our workup. Assuming that's all done, it is limited stage small cell lung cancer. Our standard approach has been to give cisplatin etoposide with radiation treatment, once a day or twice a day. It's a part of a standard treatment, 4 cycles of platinum etoposide. In some instances, patients are not candidates for cisplatin therapy because of renal dysfunction. So carboplatin is reasonable to substitute. In general, I prefer to stay with cisplatin in patients who are otherwise eligible to get cisplatin. Cisplatin has been tested the most in the limited stage small cell lung cancer chemoradiation regimens that then undergone clinical trials. More importantly, cisplatin is less myelosuppressive and then carboplatin, and that's important. I also want to remind practitioners that when we give chest radiation therapy, it is safer and perhaps better to avoid growth factors, particularly the white cell growth factor. It turns out that the use of filgrastim may increase the risk of radiation pneumonitis when you give concurrently filgrastim with thoracic radiation treatment, perhaps related to the cytokines. And that sometimes I've seen that becomes part of the practice when somebody gets carboplatin etoposide, especially when they're getting radiation treatment. Please consider holding off on giving filgrastim prophylactically. And of course, the need for acute sepsis for treatment, that's a different story. But prophylactic use of filgrastim during concurrent thoracic radiation should be avoided if possible. So that's an important, in my opinion, practice point. So 4 cycles, there is no real benefit to give cisplatin etoposide more than 4 cycles. And the important question is that do you do radiation? Do you start radiation at the first cycle, second cycle, or third cycle? And this used to be the topic of clinical trials late 1990s and 2000. And I think right now we consider doing one first or second cycle of chemotherapy, radiation starting the first or second cycle of chemotherapy. I think is reasonable. There's no real advantage. Later, delayed radiation probably is not a good idea. Sequential chemotherapy and radiation should be not be the way we treat these patients, and concurrent chemoradiation is the way we should treat these patients in general. And I'm not an expert on radiation oncology, and I would refer this to our radiation oncology colleagues. What's the optimal radiation regimen? Once a day, twice a day, the dose, etc. But I would refer the trainees and the practitioners to the papers published in the late 90s and early 2000, comparing the once a day to twice a day regimens. And it turned out that twice a day regimen was superior to once a day regimen, but the differences in the doses of radiation. And so I think today, given appropriate doses of radiation, once a day may be as good as twice a day radiation. Well, twice a day radiation shortens the duration of radiation therapy for patients, especially those coming far out of town and don't have access to radiation facility that gets done quickly. There's also higher incidence of esophagitis, so something to keep in mind. And then once the chemotherapy radiation is done, prophylactic renal radiation therapy is a topic of discussion. And I think we should discuss the pros and cons of the prophylactic renal radiation therapy to these patients. And it is something that we recommend this to our patients, but some choose not to do, looking at the delayed effects, the short-term effects, and some choose to proceed with that. And it appears to add a modest increase in overall survival, a clear maybe 3 to 4% improvement in overall survival, and a significant 20% decrease in the incidence of brain metastasis in the prophylactic renally radiated PCI patients, since nearly 60% of patients with small cell lung cancer do get brain metastasis at some point or the other left untreated. And I think it is a topic of discussion. Again, in one of those situations where we have to really understand what is driving these cancers to grow in the brain, and we really have to understand that better before we come up with better treatment options for these patients. But for now, 4 cycles of cisplatin and etoposide, or at least carboplatin and etoposide, with concurrent thoracic radiation therapy, beginning with first cycle or second cycle of chemotherapy. Once it's all done, and the patients are doing well and has a great response, and then doing prophylactic radiation is the way to go. Now, as you can imagine, an area of great interest here is, can we integrate PD-1, PD-L1 inhibitors in this combination? So there are ongoing trials done by cooperative groups and others looking at concurrent thoracic radiation therapy along with concurrent checkpoint blockade, immune checkpoint blockade with chemoradiation, or given in a consolidation/maintenance fashion, similar to the Pacific studies. And so that's definitely an approach being considered. Small cell lung cancer is a disease that continues to haunt us, partly because we understand very little about the biology of this disease beyond the basic fact that loss of p53 mutation and RB1 loss underlies this disease. And having said that, a diagnosis, these patients dramatically respond to chemotherapy, but then relapse within a few months in extensive stage disease. They do very poorly. And this is an area of intense research, and we have begun to explore this. And we have recently characterized that activation of Wnt signaling pathway leads to resistance both to chemotherapy, and we think, although we have not proven that, may even lead to resistance to immunotherapy, because Wnt signaling, Wnt pathways activation has been shown to confer resistance to immune checkpoint inhibitors in melanoma and liver cancer. We think the same mechanism may be operative here too. And so there are also other groups that have been looking at the DNA repair pathway alterations as mechanisms underlying resistance to chemotherapy. And so this is an active area of research, and it is something that hopefully we'll learn much more in the coming years. And that's what's going to help us really take us to the next level.